My exquisitely unbalanced scholars, you return for more cardiology and less sleep. Delicious. Tonight's lesson, Atrial Fibrillation, the group chat where every atrial cell texts at once and nobody moderates. Why it happens, etiology and risk factors. AF is rarely a lone wolf. Something's poking the atria. Cardio culprits, hypertension, IHD, heart failure, including valvular, cardiomyopathy, post-cardiac surgery, metabolic endocrine, diabetes, thyrotoxicosis, respiratory, OSA, pneumonia, smoking stirs the storm, others, obesity, CKD, alcohol excess, caffeine sensitivity, some, age increase, male sex, genetics. Note, can be lone AF, but that's the exception. Mnemonic, high drama SOCA, HTN, IHD, glycemia, DM, heart failure, cardiomyopathy, drinks, alcohol, respiratory, OSA, pneumonia, smoking, age, sex, M, metabolic, thyroid, after surgery, salted kidneys, CKD, obesity, caffeine, some, autosomal, family history, callback, even our squeaky hoodie pericarditis has boundaries. AF just opens the gates and invites everyone. How it starts. Pathophysiology. The triggers include rapid firing, usually from the pulmonary veins, also from the superior vena cava, coronary sinus, vein of Marshall, and atrial appendages. The mechanisms involved are automaticity, triggered activity such as calcium after depolarizations, and micro-reentry. The substrate involves atrial fibrosis and dilation, which lead to slowed and patchy conduction, resulting in multiple wavelets. Perpetuation occurs through the principle AF begets AF, which involves remodeling of ions, calcium handling, and structure. Here's a mnemonic to remember this. TSP-PUF. It stands for triggers, pulmonary vein focus, substrate, fibrosis, and perpetuators, AF leads to AF, with PUF meaning pulmonary veins, usually fire first. Knock knock joke incoming. Knock knock, who's there? P-waves. P-waves who? Exactly. How we label it, classification. Paroxysmal means it self-terminates in 7 days or less, often less than 48 hours. Persistent refers to episodes lasting more than 7 days or requiring cardioversion. Long-standing persistent lasts for 1 year or more continuously. Permanent means we've all agreed to stop chasing sinus rhythm. Valvular versus non-valvular classification is important for decisions about anticoagulation. Primary or lone AF occurs by itself versus secondary AF, which is due to another condition. How it presents. Clinical features. It can be asymptomatic, which is common, occurring in up to a third of cases. The symptoms include palpitations, which are classic, fatigue known as the sleeper symptom, dyspnea, reduced exercise tolerance, and chest discomfort or anxiety. When complications present, they may include stroke, mesenteric, or limb ischemia. Hemodynamic instability, often called fast AF, involves acute heart failure with features such as paroxysmal nocturnal dyspnea, orthopnea, and crackles, hypertension, syncope, and chest pain or myocardial infarction, often with heart rate over 150 and blood pressure below 90. There is a mnemonic to remember these symptoms and signs. PFADS. This stands for palpitations, fatigue, air hunger, which is dyspnea, dizziness, or syncope, and stroke signs, if embolic. As a light-hearted callback, unlike aortic stenosis prim and proper crescendo, atrial fibrillation is like free-form jazz. No P-wave, all chaos. How we prove it? Investigations. First line, 12-lead ECG, irregularly irregular, no P-waves, variable ventricular rate, TTE, LA size, LV function, valves, guide strategy, further adjunct, bloods, FBC, U&E, LFTs, TFTs, plus or minus magnesium, Holter, event monitor, if paroxysmal suspected. TOE, also known as TE. Look for left atrial or left atrial appendage thrombus prior to cardioversion or ablation. Detail pulmonary vein anatomy, cardiac CT or MRI. Assess structure and fibrosis, used for pre-ablation planning as needed. Mnemonic, echo tab, ECG, CHO, which stands for TTE, Holter, other labs such as TFTs, then TOE, advanced imaging which includes CT or MRI, and bloods. What we do, management overview. Acutely unwell, unstable with shock, ACS-type pain, or acute heart failure. Immediate electrical cardioversion. If stable with less than 48 hours onset, rate or rhythm control is advised. If 48 hours or more, or timing is uncertain, rate control is used if planning cardioversion. Anticoagulation should be for 3 or more weeks or guided by TOE. Here's a helpful mnemonic. Shock, shock. If shock, heart failure, ongoing ischemia, collapse, or killer hypertension are present, then the patient should be shocked, meaning cardioverted. Regarding rate versus rhythm control, rate control is the default first-line treatment unless there are exceptions, typically using a beta blocker or a non-dihydropyridine calcium channel blocker. Digoxin may be used if the patient is sedentary or has heart failure and is often added on. Rhythm control should be considered if the patient is symptomatic, has new onset less than 48 hours, heart failure due to atrial fibrillation, or by patient preference, and involves cardioversion, either electrical or pharmacological. Antiarrhythmics include V-blocker, dronedarone, amiodarone, and catheter ablation if drugs fail. The mnemonic is be cool, then be clean. Control rate first, then rhythm or ablation if needed. Anticoagulation for stroke prevention. Assess CHA₂DS₂-VASc score. If the score is 0, no anticoagulation is needed for males. If the score is 1, consider anticoagulation for males. If the score is 2 or higher, offer anticoagulation. For valvular atrial fibrillation, anticoagulant regardless. The preferred treatment is DOACs, but use warfarin if DOACs are contraindicated. Complications include thromboembolism such as stroke, mesenteric, and limb ischemia. Hospitalizations, reduced quality of life, and increased mortality can occur without proper anticoagulation. Prognosis varies with age, comorbidities, symptom burden, and success in stroke prevention and rate control. Anticoagulation is the biggest lever for improving outcomes. My luminously chaotic learners, AF is messy but manageable. Find the triggers, pick a lane, 1 rate or rhythm calm 1, and never skip the stroke shield. When the atria start a riot, You will be the calm in the code. Offer your bravest confessions below Warm 1 because I shall roast 3 comments in the comments section.